Okay. Hello, everybody. Good morning and good afternoon and good evening, depending on where you are in the world. We are introducing the first WSPID webinar, the impact of COVID-19 in the pediatric population. My name is Mark Cotton. I'm a pediatric infectious diseases specialist from Tygerberg and Cape Town, and am the president of WSPID. And it's really my pleasure to invite all of you to the webinar, our first. If I can have the next slide. WSPID is a global coalition of pediatric infectious diseases societies. There's also plenty of room in WSPID for anyone caring for children with infectious diseases. You can see the societies represented on this map. You know, we do have a global reach, and we are heading for our 25th anniversary. If I can have the next slide. WSPID has the way WSPID has functioned in the past has mainly been for a biannual meeting in a middle or lower resource setting in the world. It's been held in Latin America. The first one was in Mexico, and we are planning our 25th meeting in Cancun in Mexico. We hope that it will take place, either as virtual or in person, or a combination of both. But we are drawing your attention to this amazing meeting that's being planned. In between these meetings, WSPID is very busy doing lots of activities. If we can have the next slide. Some of the activities include research workshops by an education committee, an AMR, antimicrobial resistance working group. There's an education portal in progress. There's a scientific committee. And I encourage you to go to WSPID's website to find out more about us. And for any questions regarding WSPID, to address these questions by email to Hester, whose email address is available on all of the information on this webinar. So please enjoy, and thank you so much for attending. And also any input and any suggestions for the future will be extremely welcome. Thank you very much.
Well, good morning. Next slide, please, Hester. The next slide, please, Hester. There we go. My name is Miguel Orion. I'm from the Faculty of Medicine of the University of Chile, and I'm co-moderator with Mark Cotton for this first webinar of what hopefully will be a very interesting webinar series. And we have concentrated, as can be expected, this first webinar on essentials of COVID-19 that pediatricians need to know. And for that, we have three great speakers. We will begin with Susanna. Susanna is well known. She is professor at the University of Parma and also president of WSPID. And she will talk about the worldwide impact, the global view of COVID-19 in children. Then Juan Pablo Torres, who's also pretty well known now, pediatric infectious disease specialist, associate professor at the Faculty of Medicine of the University of Chile, whom will go into the big question of what is the role of children in transmission, which is still an ongoing question. So we'll see what Juan Pablo will tell us. And finally, we will go and address this specific, curious, relevant syndrome, the multisystemic inflammatory syndrome. And here we will have another great speaker, Marco Sáfadi, who is from Santa Casa and the Sao Paulo School of Medicine. So I invite you to enjoy. If I can go back quickly to the previous slide. This will be 3 sessions of around 20 minutes. You can, as you are listening, you can type your questions in the Q&As and we will be reviewing these. And after the 3 presentations, we hopefully will have time for around 15 to 20 minutes to address these questions. Remember to claim your certificate of participation for live attendance. For that, you need to fill the survey at the end of the webinar. We'll remind you this at the end. So with that, and without taking any more precious time from our speakers, I would like to introduce Susanna Esposito to give us an overview of COVID-19 in children.
Thank you. Thank you very much for the kind invitation to WSPID and also for the opportunity that everybody gives me for doing this presentation. I will try to focus on the SARS-CoV-2 epidemics in patients or in subjects below 18 years of age, focusing on the characteristics of the infection and the severity. This is my conflict of interest, and looking at the agenda, I will try to speak to you about epidemiology and clinical findings. Then I will focus a bit on viral shedding. Also, Juan Pablo later will speak specifically of transmission, on the topic of school closure and on the use of facial masks. So when we take into account the data, these are the data coming from the American Academy of Pediatrics. You can see that the number of pediatric cases is quite huge. Also, we can say that the pediatric population represents just about 10% of all cases. And looking at the data in terms of hospitalization and in terms of mortality, you can see that in the United States, the hospitalization rate was between 0.7 to 3.7% of the total reported hospitalizations, and between 0.3 to 8.3% of all child COVID positive that were detected. And looking at mortality, you can see that mortality rate is below 0.5% in the pediatric population. So when we take into account the clinical findings, I think that it is interesting, first of all, to start from the data that were collected in China, because in China, they demonstrated the frequency of asymptomatic cases. They demonstrated that asymptomatic cases can be detected in any age. Also, it seems that the severity is partially associated, not significantly, but in part associated with age, considering the first 2 years of life as a period of life when cases characterized by prolonged fever have been observed. Prolonged fever with respiratory distress in some cases, but without manifestations that were really more complicated than that observed in other pediatrics groups. When we look at the data that we collected in Italy in our register, we observed that in the majority of the cases, children, regardless of their age, present with fever, with cough, with diarrhea and with vomiting in a frequency higher than that observed in adults, and with systemic symptoms that at the end are those frequently observed during the influenza-like season. And however, when we look at the literature, in the literature, there are authors that reported that the first years of life are those that presents the symptoms that are more frequently severe. Also, this severity is not related to the ICU admission, because looking at this data collected in Europe, you can see that the 95% confidence interval is very high, and that it is true that the odds ratio observed in the first years of life is higher than that observed later. But there isn't a significant association between the age and the admission in the ICU. So if we consider the pediatric situation, we can say that in the majority of the cases, children presents a symptomatic infection. Then there is this large group with a symptomatic infection characterized by fever, respiratory symptoms, and gastrointestinal symptoms, with a minority of cases with ICU admission, and with the lethality rate that is quite limited. However, it is true that when we consider the ICU admission, then it is interesting to analyze the characteristics of the patients that are admitted to the ICU. You can see that there is a large median age difference between the countries. So usually, anyway, those that are hospitalized in the ICU are not children below the first year of age. When you look at chronic disease, you can see that half of the cases at least, or even a higher percentage of patients admitted to the ICU are characterized by chronic underlying disease. And you can see that the lethality rate in the ICU is higher than that observed in the normal ward and in the overall number of cases. When we consider the clinical characteristics of children that are admitted to the ICU, you can see that in a large part of cases they have gastrointestinal symptoms, especially vomiting, and in a large number of cases they have a myocardial involvement. In addition, cases characterized by neurologic and radiographic findings associated with COVID has been reported, and encephalopathy has been reported by some authors in countries like Asia and like Afro-Caribbean regions. So again, even neurologic involvement is considered a possible complications that children present when they require the admission to the ICU. And another point, but Marco will enter in details in this, is the problems represented by the severe Kawasaki-like disease that has been reported. And it has been observed that this can be a sort of Kawasaki disease, or otherwise a pediatric inflammatory multisystemic syndrome, or a multisystemic inflammatory syndrome that requires a specific therapy. Unfortunately, there isn't a real standardized approach on this, and in fact, I'm working in a group of WHO for the identification of the best therapy that should be used in the different contexts. What we can say is that where there are important outbreaks, then this case occur. And in fact, in Italy, the largest number of COVID disease and Peens or MISC disease in children have been reported in Bergamo, that is a city in Lombardy region that was largely affected by SARS-CoV-2 infection, with a large number of cases in the adult population. So if I present you the slides, we should also take in account that there is a percentage of cases between 0.5 and 4% that develop a MISC, and this MISC has a high frequency of ICU admission and death, showing that it is extremely important to avoid this kind of outcome. The first question is why children and young people at the end present less symptoms than adults and older people. There are different hypotheses. In part, it seems that the antibody response can influence these findings. In part, the immune characteristics of infants and children in the first years of life seem the reason of this response. And in part, it seems that in the first 6 years of life, the expression of ACE2 receptors is lower, and this explains why the entrance of the virus in the cells is lower, with a reduction in clinical symptoms and also in disease severity. But another point is represented by viral load, because it seems that viral load is associated with disease severity, with severe cases that present higher viral load and also longer shedding. So when we take in account data coming from Korea, that is a country where contact tracing was very strong and very aggressive, it was observed that even more than 80% of children are asymptomatic, even more than 90%. So when at the end swabs are performed, especially within the families that present positive adults, it is possible to find a large number of children that are positive and that can shed the virus and infect others. In Emilia-Romagna region, where Parma is, we have worked in a network analyzing the characteristics of cases that we detected. Also, Emilia-Romagna region was highly affected in Italy in the first wave. And in the majority of the cases, the positive children were observed among family members. So they were observed when we had medical nurses and the doctors that went at home of the patients and performed swabs to all the family. And this explains why when we look at the location where the swab was performed, if the swab is really performed at home or at the territory level, the probability of hospitalization is lower than that observed when the swab is performed in the hospital. So this means that in children the severity is less, and it is extremely important to analyze the possibility of positivity not in the hospital, but in intermediate setting that are between the hospital and the home. The other point is that when children are symptomatic, they have a higher viral load. It is not clear whether those with pneumonia or milder symptoms have significant differences. It seems that in presence of pneumonia, viral load is higher. What you can say is that in presence of absence of symptoms, at the end, 50% of the pediatric patients are negative after 10 days, whereas in presence of symptoms, especially if they are severe, the 50% of them persisted positive up to 3 weeks. And you can see that in a part of the cases, the positivity can be observed even for 6 weeks. So the point is that symptomatic infection is associated with prolonged shedding. And unfortunately, what we can say is that the role of age is not totally clear. Some authors reported that children below 6 years of age can shed the virus for a longer time, but it is not clear whether there is a difference between the shedding through the respiratory tract and the shedding through the gastrointestinal tract. That is because the gastrointestinal shedding is very long, but it seems that the main way to transmit the infection is represented by the respiratory secretions. And it is also observed that even if age can influence the shedding, antiviral therapy does not seem to influence it. It is true that only few children were treated with antiviral drugs. Now there are some studies ongoing on the use of remdesivir, but at the moment this does not seem to influence the shedding, at least in fecal samples. So if the question is why younger children can shed the virus for longer time, the problem is related to the antibody response that can be considered protective against the infection. If you look to this slide, you can see that younger children are those that present we can say a late significant antibody response. So this late response explains why children at the end presents less frequently severe symptoms. But at the same time, it explains why even in absence of symptoms, the shedding could be longer in the first years of life. In part, the ACE2 receptors can influence the reduced risk of at the end of clinical findings, but at the same time, there is the possibility that the shedding is longer. However, when we look at the characteristics of the families, we can observe, as we observed in Emilia-Romagna, that the infections occur mainly among family members and that the infections from child to child are rare. And this is a very important point because, first of all, this has implications for assistance. In our reality, we demonstrated the utility of telemedicine in the resolution of problems related to positivity of pediatric cases, but also related to suspected cases and to cases that require a clarification by swab. So using telemedicine, we were able to reduce at the end the number of children that present in the hospital. And anyway, for this role of children, in March, after our first observations, and then our observations were published after some weeks, we highlighted that probably school closure is not the correct approach to COVID pandemic, because in Italy, at the beginning, we closed all the school, thinking that SARS-CoV-2 could be similar to influenza virus, and so that children could be the main transmitters. But now we observed that children are not the main vehicles of transmission of the infection. And so the fact that school is closed can create important differences, especially because it is difficult to manage children at home, and because even the problem of disequalities can have an important impact in the possibility of learning of children, and also at the end in their psychological health. It is true anyway that children can transmit the infection in daycare and schools. And so this means that, as in Korea is done, contact tracing is extremely important. And at the same time, it is important to use hand washing, physical distance, and also to use face masks. This is the advice from WHO and from UNICEF. These are two of our manuscripts. You can see that under the age of 5, it is not recommended to use in routine practice a face mask at school, but of course teachers should use it. Then you can see that between 6 and 11, it depends on the epidemiological situation and also on the distance that the students have, whereas those older than 12 should be considered as adults, and so all the recommendations that are used for adults should be followed. Again, another important point is represented by children with chronic underlying disease, as those with immunosuppression or those with other kind of clinical problems, because in these cases, when there are students with this underlying disease, it is extremely important to be careful in order to avoid potential risk of severe disease. However, the psychological impact of school closures was huge, and this is one of the studies that summarize very well all the problems that during the lockdown phase students present. So how we can conclude? We can conclude, first of all, highlighting that SARS-CoV-2 positive children are often asymptomatic, but they can have symptoms, and in some cases, complications can occur. Then the other point is that regardless of the presence of symptoms, it seems that they eliminate the virus in a similar way to adults without significant differences and with age that could represent a problem that is associated with a longer shedding. The other point is that the vast majority of children are infected by adults within the family. The risk of transmission of infection from child to child or from child to adult seems to be very low, but exceptions are possible. And the school closure should be avoided. Also, it is extremely important to analyze subjects with suspected cases and also to use in an appropriate way face mask. Thank you very much for your attention.
Fantastic, Susanna. Thank you very much. A great overview, and certainly I remind audience we are now in 361, so that's great. If you have questions, put them on the chat and we'll look at them and try to organize the best we can for the end. So Juan Pablo, transmission in kids, what's going on? Give us a little bit of more profound insights, please.
Hello, thank you very much, and thank you for the opportunity to share and to talk about this topic in this WSPID seminar. Good morning and good afternoon for others. I'm Juan Pablo Torres, Pediatric Infectious Disease from the University of Chile, and the title of my talk will be The Role of Children in Transmission. This is my conflict of interest disclosures. So first, I think it's important to understand some key concepts and the different step of COVID-19 from the virus to the final spread to the community. The first step is the infection. So when the virus gets into the child, then the child can develop a higher or lower viral loads during the infection. And then a next step is the transmission. Finally to another child or to other adults or to the spread to the community. In this step, infection is not synonymous of transmission, and also higher viral loads are not synonymous of higher transmission. As Susanna recently showed, a viral load could be related with a long shedding, viral shedding, shedding of the virus, but in some cases, in some other respiratory viral infections, sometimes higher viral loads could be related with a strong immune response, innate immune response, for example, of interferon, that could be also related with a lower transmission or maybe lower, milder disease in kids. So it's not a synonymous high viral load with transmission, and you have to perform specific studies to address this research question. So how is the infection or transmission in children, and what data we have about that? Some of them was shown by Susanna, Dr. Esposito. This is a very recent paper in the BMJ Global Health showing the cases of COVID-19 and in children less than 20 years of age as the percentage of the total national reported cases. And as we can see here, this percentage is a little bit higher in low and middle income countries compared with the high income countries. And depends a lot in the testing strategy that each country start in the country. So sometimes are not comparable. So we have some countries here like China, Italy, El Salvador, the United States, that the percentage is less than 5%, or then some other countries in the middle like South Africa, Chile, or South Korea, and some other countries that have a higher percentage of infection detected in children like Brazil, Hong Kong, or Paraguay. This table I like a lot. Is a table done by Dr. Nigel Curtis, a pediatric infectious disease from Australia, and it's the main hypothesis related with the children transmission or infection in COVID-19, and different ideas that could be or not a real explanation for the role of children transmission. So the first, of course, is the difference that the children can have in the immune system, related with a stronger innate immune response. Children are very used to be in contact with different respiratory viruses, especially in the first 2 or 3 years of age, with higher absolute numbers of T, B, or NK cells. Children, of course, have less comorbidities, less hypertension, or less smoking. Difference in pathogen exposure, specifically with pre-existing immunity, maybe to some common respiratory coronavirus previously exposure to the usual coronaviruses, or maybe some difference in the expression of the receptors, the ACE2 receptor, that is the receptor used by the SARS-CoV-2 to get into the epithelial cells, mainly in the respiratory epithelial cells. Some other hypotheses, for example, the trained immunity effect of the BCG vaccination. But let's see some evidence about infection and transmission in children. This was one of the first papers that performed a very huge testing by PCR. 6% of the total Iceland population was tested in two different strategies, target testing or population screening testing. And as you can see here in the graph, the detection by PCR of SARS-CoV-2 in children less than 10 years was significantly lower compared to people over 10 years of age. Also in the target testing strategy and also in the population screening strategy. 6 compared with 13% of detection by PCR. Here you can see another data that is a recent study from South Korea. They observed that when the index patient is a children less than 10 years of age, the percentage of the positive in the contact tracing is significantly lower, around 5% compared to adults. But children between 10 to 19 years of age, so adolescents, showed a percentage of positive similar to adults, but some concerns about the responsible of the infection transmission in this present study can be done if you review the study. But it's the data and recent data from South Korea. Another data from the Netherlands. In Europe, here you can see the correlation between the infector and the infectee. So the one what was infected and the responsible of the infection. And most of the people infected was infected by other person of similar age. If you have 50, probably your infector was a friend around 50 years of age. But when we see the people less than 20 years of age, again, there are practically no cases. This is a primary care report in the Netherlands, suggesting a low role of children in COVID-19 transmission. Then we start receiving some evidence about the expression of the ACE2 receptor in children and adults. In this case, this study was done in a cohort of more than 300 subjects not infected by SARS-CoV-2. This is an asthma cohort study with asthmatic and non-asthmatic subjects, but they had a nasal epithelial sample, so they were able to study the ACE2 expression in these epithelial samples, and they found that was significantly lower in children less than 10 years of age compared to people over 10 years on adults, and they observe an increase of expression of this receptor ACE2 depending on the age. And the other factor that could be important is the endothelium. Endothelium is a real organ in the body, and this is evidence from autopsy in adults that SARS-CoV-2 can be detected by electron microscopy in the endothelium. And probably we can find an association between healthy epithelium or damaged epithelium that could be related with lower or higher severity of the SARS-CoV-2 disease. Of course, children tend to have a healthy epithelium because they have less hypertension, smoking, or obesity. Sometimes not. In Chile, we have very high obesity here in our country. And this healthy epithelium could be related with less severity of the disease or lower susceptibility to the infection of SARS-CoV-2. And related with the viral loads, Susanna just mentioned the relation of viral load with the viral shedding. This study was done in 145 patients in Chicago, in the US, and they studied the viral loads in mild to moderate illness according to the age. And as you can see here in the graph, when in children less than 5 years of age, the CT value in the PCR, that is correlated with high viral loads. Higher viral loads were found in children less than 5 years of age with mild to moderate illness compared to older children between 5 to 17 years of age, and also compared to adults. But as I mentioned previously, that's not synonymous that if you have higher viral loads, these children transmit more the virus. When we see another data in symptomatic neonates, children and adolescents, if higher viral loads are correlated with more positivity in the cultures, so a possible sample that can transmit the virus, viable samples. So you can see, yes, that's right. If at higher viral loads, it's more possible to have culture positive samples. But again, it's not synonymous that these samples result in a higher transmission level to the community of the SARS-CoV-2. This is another very interesting, and we can have a lot of discussion. This paper published in the Journal of Pediatrics at the end of August from the hospital in Massachusetts. They studied children between 0 to 20 years of age, 192 children. Some of them have Peens also. And as you can see here in the graph, related with the viral load, children have higher viral loads, especially in the first 2 days on the onset of symptoms in the course of the disease. Then they have a trend to decrease in the first week, and then until the first month of the disease. And they compare the viral loads observed in adults, hospitalized adults, and they were significantly lower. But the comparison here in this work is not very fair, because they compare the initial viral loads observed in children in the first 2 days of the onset of the disease with the viral loads observed, and this is significant, with the viral loads observed in adults, or hospitalized adults, but at the end of the disease. So this could be a bias in this significant observed difference. But also, it's interesting because in this study, they observe the ACE2 expression, but now in people infected by SARS-CoV-2, and again, the ACE2 expression was significantly lower in children less than 10 years when they compare with the people over 10 years of age. So probably this is a real factor that can contribute to less susceptibility to the infection of SARS-CoV-2. And also, I agree with Susanna, the school closures are a very relevant issue in the context of the pandemic. Recent data 3 days ago from the UNICEF showed that around 50%, the half of the total enrolled learners, children around the world, are affected by school closures. In our group in Chile, we already performed a study, it's already published in the CID journal, to assess the antibody prevalence in blood, IgG or IgM, in a large school community outbreak that we observed in Chile. Also was the outbreak that caused that the Ministry of Education closed all the schools in Chile from March until now. And what we can find after we study more than 1,000 students, children, and more than 235 adults of the community school. Well, again, when we see the data about how many antibody testing we detected, was the half in the students, around 10% after we studied this after 2 months after the outbreak, 10% compared to 20% that we detect antibodies, positive IgG and or IgM in teachers. It was interesting because we also performed a respiratory or symptomatic interview to the subjects, depending if they were positive or negative for the antibodies detection. And of course, symptoms were more frequent in people positive for antibodies, staff or student, adults or children were more positive. But it's also interesting to see what happened in the positive one, children and adults, when they were asymptomatic, no symptoms. And we found in people positive for antibodies in children a higher percentage, 40%, compared with 18% of asymptomatic patients or subjects in this report studied at the community level. Schools are very relevant probably for transmission. And here you can see the different levels that were studied in the school, and the dots are the teacher positive in each class. But probably one of the main important questions here is which is the direction of the transmission, who affects who. And in this study, and also I will show you another evidence, most of the cases, the direction of transmission is between adults, parents, from adults in households, caregivers, teachers, and in a less way, the direction of the transmission is between children's or children classmates. As I mentioned, here is another English study, a study from the UK, from the Dr. Shames Ladani's group. It's a very interesting study because done in the National Health System, and it's a surveillance between June to July 2020, when they reopened the schools, and what happened in this surveillance that considered more than 20,000 schools in the UK, and involving more than 1,500,000 people, children in those 20,000 schools. And they observed only 30 outbreaks, and in 23 out of 30 outbreaks, the direction of the transmission was between adults to adults or adults to children. Again, similar results that we observed in our study. Well, of course, in the UK, they take a lot of strict measures when they reopen the schools. They manage bubbles between teachers and children, and the assistant to the school is not compulsory, it's voluntary, and they started with the smaller kids in the lower levels, and also they found a stronger correlation between the presence or the number of outbreaks with the COVID-19 regional incidence. And I mentioned this correlation that was significant because one of the first step probably to decide or not to reopen the school is that the COVID-19 transmission at the community level should be as lower as possible to think to reopen the schools. Also, similar situation was reported from Australia. This is from Lancet Child Adolescent Health Journal, where they study 15 school and 10 early childhood education care centers. And you can see here they observe some primary cases, 12 children and 15 adults infected, and they studied 1,400 contacts were monitored, and only 18 secondary cases here in this color, not in green, the other colors. Only 18 secondary cases were observed with an attack rate of only 1%. So similar evidence related with transmission inside the school communities. So in some countries, this is the experience of Denmark after they reopened the school. You can see here the R value, the R effective value, and 2 months after the school were reopened, they also at this moment have a RT less than 1. So probably suggesting not a very high impact in community or national transmission. If you take all the measure, you start reopen the school with strict measure, lower transmission at the community level, and also probably good testing and good contact tracing established in the community schools. Because there are some other examples, for example, Israel, that when in Israel they open schools, well, probably with all not this strict measure, they start to observe in the country and a significant increase in the cases per million people infected by SARS-CoV-2, but also sadly an increase of cases of death in 1 million people after Israel opened school. This is association, is not causality exactly, but probably was related. And then This is a very recent meta-analysis. It's interesting, again, to address the susceptibility of SARS-CoV-2 infection among children and adolescents compared with the adults. And this is probably the main result of this meta-analysis, including 32 studies here. And children and adolescents younger than 20 years have 44% of lower odds of secondary infection with SARS-CoV-2 compared with adults 10 years and older. So again, around the half. And this finding was most marked in children, as lower the age was more marked compared with the adolescent, as you can see also here in the graph of this meta-analysis. A report from the US, a very recent report in the MMWR, showed that the COVID incidence among school-age children, this is very huge number, and they divided the cohort in two cohort groups: children aged 5 to 11 years of age, more than 100,000 children, compared to the second group, 12 to 17 years of age, more than 175,000 children in the other group. And they observed that the COVID incidence was significantly lower here in the small dotted, that was the group between 5 to 11 years of age, compared to 63% of COVID incidence in the group of older children. And finally, this is a report from Scotland. It's very interesting. It's not yet peer-reviewed, but here more than 300,000 healthcare workers in the healthcare system in Scotland was studied, and the risk of COVID-19 infection and the risk of hospitalization with COVID was correlated with how many children live with in each household with this healthcare worker. And you can see here that if these healthcare workers have 1, 2, or 3 kids living in the household under 12 years of age, the risk of hospitalization of COVID-19 decreased. So probably, again, more evidence about the transmission in Chile. So finally, we can say, and we have some learnings at the moment, that the infection in children probably is at least half of the infection that we observe in adults or in older children. And most of the cases, the transmission occur and the infections occur in the household, at the household level. The viral loads could be different, but could be high also, not only in symptomatic, also in asymptomatic children. And the transmission probably is lower than we initially expected, and also lower that is compared with other respiratory viruses, as Dr. Esposito mentioned, for example, influenza, where the kids are very main drivers of the transmission of the infection to the spread at the community level. So at the end, understanding, I think, the transmission of SARS-CoV-2 in children goes beyond the clinical relevance. It's our responsibility, it's critical for taking a comprehensive care of the mental, the physical, and the social health of our children, and could help us to have a better public decision making, and also in a equitable way. Thank you very much.
Fantastic. Thank you very much, Juan Pablo. Fascinating, certainly. Many questions are coming up. We probably will have a sole seminar later on relating on what to do with schools, as we know that this is one of the hot, big topics worldwide, and with incredible debate. We will try to address some of the questions at the end. To the speakers, you can look at the question and answers, and you can also answer directly already to some questions that are posed there. So fantastic, and let's move then to the other spectrum, our young babies and kids that are having this strange syndrome that surprised us all. Marco, tell us about PIMS, inflammation in kids. Marco, you may need to turn on your...
Well, it's already turned on.
All right.
Can you hear me?
Perfect.
Okay. Well, thank you, Miguel, for the introduction, and Susanna and Juan Pablo, Mark, and all the attendants. Well, the very last part of our webinar will be touching on this pediatric inflammatory multisystem syndrome that was described recently, as Miguel pointed out. And I must say, Miguel, that this is maybe the most intriguing manifestation of the COVID-19 in children so far that we are observing. And the idea of my presentation is really to share with you what we learned so far. And the first point that I would like to highlight to all of you, there are a lot of uncertainties regarding the presentation of this syndrome, and also with the ideal therapy that should be prescribed to those kids presenting to our emergency rooms with the syndrome. So this is my conflict of interests. And I started my presentation with one provocative slide. I think Susanna did a great job presenting the global impact of COVID-19 in children. This is just a summary of what we already have and some highlights to provoke the audience. Here I have data from several parts of the world, and there's no big difference in terms of the what we are seeing of the impact of this disease in the different regions. So in Asia, in Europe, in North, and now also in Latin America, we are seeing pediatric cases representing maybe less than 10% of the total cases confirmed associated with COVID-19. And it's important to highlight that children and adolescents, they represent like 25 to 28% of the population in those regions. If we go to US, they reported very nice data showing that the United States children and adolescents up to 21 years of age, they represented 80% of the hospitalizations and 0.1% of death associated with COVID-19. And I share with you data from Brazil. It's not that different. In Brazil, 0.6% of the total death associated with COVID-19 were reported in children and adolescents up to 19 years of age. This is also interesting data that were recently presented, because we should acknowledge that we have limited data on the real risk groups in children and adolescents. And the reason that I bring this data here is just to highlight one point, which is obesity. So these are the risk groups found in US regarding death. You see that 3 in each 4 deaths were occur in children with comorbidities, and obesity played a significant role as a comorbidity, present in 27% of the death reported in US. And the last provocative in this slide is this information. I got data from our surveillance system in Brazil, and as all over the world, influenza in 2020 it was really mild in the Southern Hemisphere. But I looked at the percentage of death that were reported in Brazil associated and confirmed with influenza, comparing to the proportion of death associated with COVID-19 in children and adolescents. And as you can see here, we have around 12% of the influenza associated death occurring in children and adolescents, versus, as I pointed out, 0.6% of the death related to COVID-19. So as first slide presenting, I just would like to really highlight that although SARS-CoV-2 infection in children are generally asymptomatic or mild, that's what we are seeing. We have to acknowledge that there is increasing identification of a rare pediatric inflammatory multisystem syndrome that we'll have the opportunity to review in the next minutes. Interestingly, also in Asia, this syndrome was not reported. So the first place where the syndrome was reported was in Europe, almost at the same time in UK, in Italy, in France, and in Spain, in all the several countries. They identified this new syndrome. This is a really emblematic publication that came in Lancet in early May, where a cluster of children with hyperinflammatory shock, with features very similar but not identical to Kawasaki disease, and sometimes overlapping also with toxic shock syndrome. This cluster was reported in England. The patient's signs and symptoms were temporarily associated with COVID-19. They were not occurring among the cases that had COVID-19, symptomatic COVID-19. These signs and symptoms of this inflammatory syndrome did not occur at the same time of the disease, but 2 to 6 weeks after disease occurred in those children and adolescents. All of the children reported in this cluster in England, they have serological evidence of infection with SARS-CoV-2, but only one of those children has a positive PCR in the analysis. So clinical symptoms were mainly characterized by an intense inflammatory picture. All of the children had fever. Most of them had a rash, mucocutaneous alterations, conjunctivitis, gastrointestinal symptoms, and some of the kids ended with shock and being admitted in ICU with elevated markers of inflammatory and cardiac injury. So in North America, it was also reported almost at the same time of this multi-system inflammatory syndrome. They already started to being reported in US. So more or less at the same time, the CDC, the Royal College in England, and also the WHO published some case definitions for this syndrome. And I must say different case definitions and different names. So I will keep the very first name, which was Pediatric Inflammatory Moody System Syndrome, or Peens, the acronym. It's also known in US by MISC, Multisystem Inflammatory Syndrome in Children. This is the case definition by CDC. Children and adolescents up to 21 years of age presenting with fever, and attention, the CDC definition means more than 1 day, only 1 day of fever, lab evidence of inflammation, and inflammation is including but not limited to CRP, ESR, procalcitonin, fibrinogen, D-dimer, ferritin, LDH, interleukin-6, neutrophilia, lymphopenia, and hypoalbuminemia. These are evidence of the lab markers of this pediatric syndrome, and also evidence of clinical symptoms of severe illness requiring hospitalization with involvement of at least 2 organ systems, including cardiac, renal, respiratory, hematological, gastrointestinal, dermatologic, or neurologic. Obviously, without a plausible diagnosis for this presentation and positive PCR for SARS-CoV-2 or a serology or antigen test. If you have all of these tests negative, but you have epidemiological link showing that the case has exposure to a suspected or confirmed COVID-19 case within 4 weeks, it's also a criteria to fulfill this CDC case definition. This is slightly different case definition from WHO. The age group goes up to 19 years of age. The definition is at least 3 days of fever. And again, 2 of the following evidence of clinical compromise, very similar to what is reported by CDC. Also abnormalities and evidence of markers of inflammation. No other plausible diagnosis for this presentation, and evidence of COVID-19 by tests or, again, by epicontact. Well, among the uncertainties, I started with the pathogenesis of the Peens. So Juan Pablo also shared with us that for this virus to enter the human body, the virus needs to be binding to the receptor, which is the ACE2, highly expressed in different tissues, expressed in lung, alveolar cells, cardiac myocytes, vascular endothelium, immune cells, etc. And maybe this is a clue for the real systemic inflammation and characterization of this syndrome of COVID-19. Again, SARS-CoV-2 may trigger inflammatory and immunological reactions in an unbalanced, dysregulated way. We have to have in mind that most of the cases of Peens are not occurring at the same time of an infection, but usually approximately 2 to 6 weeks after those kids were infected, showing that probably all of these alterations are not directly related to viral invasion and to SARS-CoV-2 replication, but to the immune responses related to this infection. So maybe these immune responses in some kids, they work in an exaggerated way with intense systemic inflammatory response. There are some data showing that the antibodies may attack cells expressing viral antigens or cross-reacting antigens, so host antigens that mimic those viral antigens, which makes sense in terms of the intense inflammation that is then generated, formation of immune complexes, and viral superantigens. This is an information that I also would like to highlight to you. There's a recent publication in Pediatrics and an editorial on this publication showing that anti-RBD, the receptor bind domain of the virus, so these antibodies were associated, potentially associated with an exacerbated pro-inflammatory state, which will be behind the pathogenesis of this pediatric inflammatory syndrome. It's different from Kawasaki disease. All of us as pediatricians, we know quite a lot of Kawasaki disease, also around some uncertainties, but there are some genetic predispositions associated with Kawasaki disease, with East Asian individuals, increased risk in first-degree relatives of affected individuals. We also searched for an infectious organism that could play a role triggering Kawasaki disease, and these are the clinical definitions for Kawasaki disease that for some cases may overlap with the definition of pediatric inflammatory syndrome. Among the most important distinct features compared with Kawasaki disease, I would highlight that those cases of Peens, they are definitely occurring in older age groups when we compare to Kawasaki disease. So the median age, as I will show you written in a couple of minutes, is usually kids between 7 and 10 years of age, contrary to Kawasaki disease, with the median age is usually between 1 and 2 years of age. We are seeing a predominance of African and Hispanic origin. obviously a wider clinical spectrum, a diffuse endothelial involvement, definitely a higher inflammatory markers in Peens, and an increased risk of cardiac injury and also a risk of shock. In terms of immune responses, there are some very preliminary data showing that we have definitely different inflammatory responses in those two diseases. In Kawasaki diseases, interleukin 17A is suggested to be the main mediator of inflammation, while in the Peens cases, they appears that this inflammatory process appears to be driven mainly by interleukin 6 and interleukin 8, which may play a role in this myocardial dysfunction. Now I will present and share with you some case series with a summary of the manifestations. This is an important case series from US, and 8.3 years of age, the median age in those in this case series of almost 200 kids. 60% of them were male, 73% previously healthy, and this is a very common finding in those Peens cases. And gastrointestinal involvement in almost all cases, 92% of the cases showed GI involvement, cardiovascular involvement in 80%, thrombotic and hematologic in 3 in each 4 cases, mucocutaneous and also respiratory compromise. 80% of those kids were admitted in ICU to highlight the seriousness of these presentations. 20% were ended in mechanical ventilation, and almost half of them needed inotropic support with a 2% case fatality rate. Among the therapies used in those cases were mainly treated with immunoglobulin, IV immunoglobulin, corticosteroids, and also some interleucin inhibitors, as I will show it. As I will show you in a couple of minutes. This is also a very important publication that I would like to share with you and make total sense, because one of the points that this publication highlights is the difficult diagnosis with other similar diseases, and also they were able to really classify 3 different class presentations. The first one were kids with severe presentation, presenting with shock, with or without ventricular dysfunction, abdominal pain, and marked elevated inflammatory markers. 9 years of age were the median age of those kids, most of them showing serologic positivity to COVID-19. So IgG positive for COVID-19. The class 2 in this publication were patients more likely to have respiratory distress syndrome. So probably those kids were more related with acute COVID-19. And when we look the lab data of those class 2 kids, most of them, 80%, were PCR positive, which makes total sense in terms of this definition, contrary to the other 2 classes where the percentage of PCR positive kids were really low. And the last class were the Kawasaki disease-like presentation, overlapping with Kawasaki disease, with evidence of systemic inflammation. And one difference here among those 2 other classes is the lower age, the lower median age of this group. And again, take a look. Obesity was the most commonly reported underlying medical condition in this case series from US. And they highlight that the initial profile of lymphopenia, thrombocytopenia, hyponatremia, and abnormal creatinine could help us to distinguish critically ill Peens patients from those classical atypical Kawasaki disease or even more benign acute inflammation, but is definitely needed best quality criteria to really distinguish Peens from other severe infections. Just a highlight from Latin America to show you our data. So far, we have limited International Journal of Infectious Diseases by Juan Pablo and colleagues from Chile. We have 3 case series from Brazil and 3 case reports. And until week 37 in Brazil, this is official data. We had 600 cases of Peens reported in Brazil, of which almost 400 were already confirmed and as Peens, with 23 deaths. And these are data from our hospital. Higher number of cases and intense circulation and transmission in the city. We observed, you see here in green, the Peens cases in our hospital so far without any death in our hospital among those Peens cases. Just showing 2 of these cases with you. This is an adolescent, 3-year-old adolescent that started with fever, headache, and anosmia. And then a couple of weeks later, she was admitted with shock, was admitted in ICU, mechanical ventilation, with cardiac injury. We also looked at neutralizing antibodies in those kids. We are doing to see if they are associated, and we observed positive IgG with neutralizing antibodies and left ventricular dysfunction in this adolescent that was discharged after almost 2 weeks of admission. And this is also an interesting child that came to our hospital a couple of weeks after being infected. She started with hemiparesis. So it was a facial and also a complete hemiparesis. It was also admitted in shock, went to the ICU. We started, beside antibiotics, IV, IG, corticosteroids, anticoagulation therapy, and she was discharged after almost 3 weeks of hospitalization with a significant improvement in this hemiparesis. This is a publication from São Paulo in Brazil showing direct SARS-CoV-2 detected by PCR and also by electron microscopy in a child that died with a cardiac injury. I think Juan Pablo showed data from adults. This is data from an 11-year-old girl. And to finalize my presentation, I will just share with you in the next slides what we have in terms of treatment. This is just to show that so far, most of the cases are associated with good prognosis. The management is something that we still lack some robust data. This is the guideline summary from JPIDS in US, showing that IV immune globulin was used in almost 80% of the kids in those case series. Corticosteroids in almost 6% of the cases, showing that those 2 interventions are really the first line therapies, either alone or in combination, with other agents being considered in some refractory cases. We also highlight the importance of in the beginning to start with antibiotics, since there are some differential diagnoses that should be covered among the kids that are admitted. In this review, 82% of the children survived and almost 2% of the children died. This is also data from the Kawasaki registry, showing the different interventions and the proportion of cases that are being treated with these immunomodulatory initiatives. These are the proposed approach in terms of lab exams and recommended dosage. I think we can discuss this later, but the summary of these recommendations is that so far, the key therapies that should be addressed for those kids remained in IV immune globulin, 1 to 2 grams per kilogram IV, together or not with corticosteroids, depending on the case, depending on the presentation, depending on the severity of those cases. And among the back drugs that should be used in those cases that are refractory to the treatment, we highlight the importance of the interleukin inhibitors, anakinra, tocilizumab, and other interleukin inhibitors that have very limited experience in pediatric patients. So our recommendation that if you need to use these drugs, you should use them under protocols to really generate data that we could use. So in conclusion, already, although rarely reported, the true incidence rates of Peens following an asymptomatic or mild symptomatic SARS-CoV-2 infection in children is yet to be determined. It appears to be rare, but we have to acknowledge that we don't know exactly these incidence rates. Several patients require ICU admission and aggressive immune modulatory therapies, which is the mainstay of the treatment. We should use mainly immune modulatory therapies. There is an exception that are the cases that you have positive PCR when you could consider the use of antiviral together in the treatment, only among those cases that you are able to identify PCR showing that maybe this is an acute COVID-19 case. The pathogenesis is likely mediated by the immune system rather than the virus. And I finish highlighting that is imperative. And this is something that I address now, taking the opportunity that I have a large audience for all over the world to establish a real international research collaboration to really generate data that could help us to really find which is the ideal treatment of these kids that present with this pediatric inflammatory mood syndrome. So I finish my presentation now, Miguel and Mark, and I hand to you to our Q&A session. Thank you.
Thank you very much to all of the speakers, Marco, Juan, Pablo, and Susanna. We've had lots of questions coming through, and we also are kind of running out of time, but I think let's see what we can do in the next couple of minutes to answer some of the questions. If we can't answer them now, we will be dealing with we are planning a specific session on schools a bit later, so we might not do all of those. But I would like to just ask about updates in treatment for SARS-CoV-2. Maybe Susanna, is this something you can answer?
Yes. You know, I think that the first issue is, of course, that in the majority of the cases, children could be managed at home without any kind of treatment. So this is the first issue, because in our region, we observed that when the approach at the territory level is good, and so there is the possibility to perform swabs not in the hospital but in intermediate structure, in the parking, or otherwise even at home, then you can reduce the number of those that arrive to the hospital and that enter in a vicious circle that can complicate their management. Then, of course, if there are severe symptoms, I think that the issue is how to treat and when to treat. So among the available drugs, now remdesivir is the only antiviral drug approved for use in the adults. But there are studies, approved for use against SARS-CoV-2. However, there is one study ongoing on its use in children. At the moment, there are probably less than 10 children that have been enrolled. Anyway, this could be an approach that should be used. The other point, but I think that Marco can enter in more details on it, is related to the treatment of MISC or in any case to other conditions that, for example, have myocardial involvement and so on. And in these cases, corticosteroids, for example, in some cases immunoglobulin, in other cases, at the end, thromboembolic therapies have been considered useful. What we can say is that now there isn't a standard therapy even for complicated cases. Different centers have used a different approach. There are also some case reports that have been published with the use of anti-IL-1 or anti-IL-6 treatment in children. And the other point is whether to use antiviral together with anti-inflammatory drugs, because we know that in the case of the pediatric population, the main problem seems represented by the inflammatory response. You know, I am an ID specialist, and I think that when you have an infectious disease, anyway, antivirals should be used if symptoms are severe. So I think that the antivirals for severe cases should be considered, and in addition, the anti-inflammatory drugs should be taken into account, starting from steroids and then improving the level of the anti-inflammation according to the clinical data that you have.
Thank you very much. I have a question about the anti-RBD antibody, which is really new, and there are two questions on this. And the one is, what is the, is this something that could be induced by any of the vaccines? Is this something we need to worry about?
Yeah, I think I would like to touch on this and also to. I totally agree with Susanna. We had a lot of different options in terms of therapies, but I think that antiviral use should be reserved, taking in account how these cases occur, and taking in account that most of them you don't find the virus circulating, and you see immune responses generating the syndrome. So the antiviral use should be reserved for those acute cases where you are able to identify the presence of the virus. And this is the case. These are the cases that I think make sense to also use the antivirals, as Susanna pointed out. And the mainstay of the treatment is really related to the immune modulatory therapies. And I think this provocative question, Mark, is one of the most important questions for us pediatricians. And I just touched a brief on this when I pointed out that anti-RBD antibodies may play a role as the pathophysiology of those Peens cases. So it's plausible to think that once a child is vaccinated, depending on which kind of antibodies these vaccines may produce, we could see theoretically a risk of occurring this kind of immune responses once the child is, after being vaccinated, infected with SARS-CoV-2. So I think it's crucial to really have very robust safety data and data with these vaccines on children before starting use vaccines in children, as we are seeing all over the world as something that would really be a changing scenario. So I think that this is something that really is important to highlight.
If I can jump in quickly, Mark, I would ask Marco and Susanna, which antivirals are we talking about? And in this real world, we don't have.
Okay, that's a good point also. We have very limited data in adults and even more limited data in children, Miguel. But the very limited data in children we have so far, and all of these guidelines that we have the opportunity to revise, etc., they mainly talk about remdesivir. So remdesivir is the antiviral that theoretically could play a role among these kids. But again, we have to acknowledge with very, very limited data so far. Convalescent plasma, very limited data so far, especially in children. ECMO, already very, very limited data so far with the role of these interventions in kids.
I totally agree with Marco. Absolutely.
Thank you, and I think you've dealt with a couple of questions in the chat box. I wanted to ask a question from Florette about the French study with the high mortality in children. What was going on there?
Yes, I think that anyway, in that study, they included symptomatic children with comorbidities. And so this can explain the finding that was different from all the other available information.
Thank you. And then a question for Juan, Pablo, to try to explain a bit further the lack of correlation between viral load and infectivity. What is going on there? It's very confusing to me.
Yeah, it's a very good question also, and we have to learn a lot yet, I think. But the viral load, we have to consider that viral load is a representation of the stage of the infection in the children. So then the viral load, and this happened in many respiratory viral infections, could be the trigger for different immune response in children. For example, in RSV, we see a lot of interferon response depending in higher viral loads. If you have much virus, higher viral loads, probably you have more interferon, so you have more defense for the virus. And maybe this can be related with a milder disease. I don't know if Susanna also agree, because there's a lot of discussion at this moment, at this time of proposal. So you cannot suppose that if you have viral loads, that means transmission, and that means that is also infectivity related, because the detection of respiratory virus most of the time is by PCR, is an acid nucleic acid detection. And we know that, as Susanna mentioned, you can detect by PCR probably many days the virus in not only in the respiratory tissue, also in fecal tissue or in stools, you can detect for weeks. But this doesn't mean that it's a contagious viral particles at this moment. Even the culture, when you perform culture, most of the evidence show now that the cultures are positive until day 8, more or less, not more than 10 days and after. So that's why we have to have a comprehensive analysis of the PCR detection results. Probably Susanna can complement my opinion, and what do you think about that?
Marco also was raising his hand.
Yes.
No. First, totally Susanna, agree. Please. Ladies no, first, always.
I totally agree with Juan Pablo, because the point is the meaning of a positivity of PCR, especially after several days. However, unfortunately, at this time, we don't have, we can say, a burden of viral load that can be considered infective, first of all. And secondly, you know, when you have an outbreak, it is very difficult to analyze a single case. It is easier to recommend the isolation. Another issue is represented by the fact that, for example, in a family, you can have some family members that already had the infection and that have a serologic response, but another family member that was negative that acquired the infection. So it is not known even the minimum level of antibodies that can be considered protective. And even in these cases, families are closed at home in quarantine because of the risk of transmission. So we have several open issues related to viral load in terms even of infectivity overall, but also in terms of minimum level that is associated with severe symptoms. And also, I think that there are open issues in terms of antibody response.
Okay, thank you very much. So,
Mark, may I just add one point?
Yes.
Just one point, because I think your question, Mark, makes total sense. And for me, I have the same always doubt. So what is the meaning? If you have a high viral load, why shouldn't you infect as well as an adult? And maybe the one explanation that could be this, and I agree with Susanna and Juan Pablo among the points, these are RNA, viral, but let's assume that is not only RNA, it's viral load and it's also viable virus. And we can prove that together with the viral load, we prove that the culture virus in those kids are in the same proportion and levels as in other age groups and adults. Maybe one point is that, let's assume, Mark, you have 100 children infected with high viral loads, or with viral loads as high as 100 adults in the age of Juan Pablo infected, a young guy, etc. So I will assume that among those 100 kids, 80% of them will be asymptomatic. Another almost 20% will be mildly symptomatic. But in the age group of Juan Pablo, young guys, 100 infected, most of them will be symptomatic. And the symptomatic infected persons will cough, will have coryza, will have vomiting, will have diarrhea, etc. So this may play a role in the transmission when we compare to children that most of them will remain asymptomatic, so less likely to transmit.
Thank
So
you.
just to complement, because it's not only depend on the virus, depend on the host, and children are not small adults, and also that's why we can see this special presentation like Peens in children that is very unusual, not in adults also.
We will baptize that as the Sáfadi hypothesis.
Okay.
Great. Thank you.
That is brilliant. Thank you, everybody. And we are actually going to have to close it now. And there are certainly a lot of interesting questions. We are going to have another webinar with a COVID theme. We were probably on schools. The webinar will be available, I think, from the website to review again. In terms of unanswered questions, we will do our best to answer those questions as well. And we will have to find out whether the best way to do that, because there are certainly lots of questions. And as long as there are lots of questions, we've got lots of work to do, or you've got lots of work to do to find the answers, maybe collectively all of us. But anyway, just to thank the participants, Miguel for co-chairing, the Hester for logistical support, and our speakers, Susanna, Marco, and Juan Pablo, for the most superb talks on a perplexing subject. And we look forward to this platform to continue addressing problems in pediatric infectious diseases. And everyone keep well. Goodbye.
Ciao.
Bye.
Goodbye, and thank you very much. Bye-bye. Ciao, ciao.
Thank you.